Another bit of research that I've been involved in for a number of years, again with a lot of support from CCLG, is looking at chickenpox. So couldn't really be further from national NDTs. So I'm just going to whiz through some thoughts about some studies that I've been involved with. So first of all, chickenpox in children with cancer. Why is it such a problem? The main problem is that when children are well, and there's great charities that organise wonderful trips and parties, and they go to school, and unfortunately one of those children will have had a contact with chickenpox, and it makes a huge difference to all the other children because their immune system is obviously quite depressed. And what can often happen from that is that we then need to think about how to prevent it in the most effective way possible, so these children don't actually have to stop their treatment as a result of having chickenpox or end up in hospital to have treatment because they've actually developed it. So, oh, that's gone the wrong way. The two ways in which chickenpox is prevented in children with cancer, so if a child has a contact with someone with chickenpox at a party, usually a Christmas party, there are two ways in which it can be prevented. One is using acyclovir, which is an oral antiviral medicine that's given for 14 days and costs about £7, but does need to be taken 4 times a day, so can be a bit of an issue for some children. And the other one is immunoglobulin, which is given as a blood, well, it is a blood product, and is given into the muscle. It's a one-off injection and lasts about 3 weeks in total in terms of protection, and costs about £350 a vial. So when you think about cancer research, we're thinking a lot about that today. There isn't any other way in the whole country that we would have 2 such different treatments for the same problem. So you would never be able to treat a child with leukemia with such completely different medication in a completely different way that costs so much difference, and children tolerate them in completely different ways. But yet for something as sort of common as childhood chickenpox, we haven't quite decided which is the right way. So this led on to a pilot study where we tried to look at which of those was the best method. And this we've already heard from the CRUK Clinical Trials Unit, and they sponsored this study from CCLG and NIHR. So we had a really strong research background in terms of infrastructure for this study. It was a pilot, so we just wanted to see if it was going to work, and we did it in a number of centres across the country, including Manchester. We opened 6 centres over 13 months, and we thought we would randomise 50 children. So this is just randomised 1-to-1. You'll either get the injection or you'll get the oral one. We screened 482 children, and there were 16% of them that were eligible for registration. We registered 32, but only randomised 3 children. So, and all of those 3 were randomised to receive acyclovir, which is the oral medicine. So that's a lot of work, a lot of money, and we still at the end weren't able to answer the question, which sometimes does happen in research, I'm learning. So the reasons for why we had such a poor randomisation rate, there were a number of families that declined to be registered. Some people said that the distance to the trial site was too far for them. The additional oral medications, obviously many of these children are taking lots of medicines already, and actually if they got randomised to the one that needed 4 times a day medicine, that was too much for them. Additional blood samples, families weren't keen to do that. Declined as no longer had an NG tube, and declined as patient back at school. So those were the reasons that we found out, and that's why we do a pilot, is actually to pick up on these reasons, to find out why things haven't worked and what we can learn for the next time. So the lessons that we learned is that we needed to extend our eligibility criteria. For example, children that had previous VZV, which is another word for chickenpox, weren't retested. Actually, that year that we did the pilot, it seemed to be lower chickenpox rates than ever before. So that was just really bad timing. And also the aspect about shared care. So there was a lot of parents and families that fed back that actually it was just too onerous for them to expect to travel to their primary treatment centre, and the number of blood tests required as well. So if at first you don't succeed, you call it version 1.0, and I think this is kind of the backbone of all research, is that you have to just go back and ask the same question in a slightly different way. And actually, you know, that's the point of doing pilots, that you don't actually invest millions and millions of pounds into doing something that isn't going to work. So this is where PEPtalk3 comes out, version 1.7a. So then it was a case of phoning a friend. So Public Health England, clearly much bigger organisation, they're actually in charge of all the immunoglobulin administrations. They are the kind of the gatekeepers, if you like. So they sort of said, well, hang on, we know who's coming in and who's needing the immunoglobulin, so we can help you with this. So CCLG said that they would help as well, which is great, and St George's have got some infectious disease expertise down there as well. So we thought, okay, let's just answer this question in a slightly different way. So what we did is we asked people just to do what they normally do. So there's no randomisation in this. There's no kind of choice as to which treatment you get. You just do what you normally do in your normal centre. And suddenly, everyone wanted to take part, because it was just an audit, really, of saying, this is what we do, this is how many children we've given this intervention to, and this is whether they got chickenpox or not. And it's not the best way to answer this question. Obviously, the randomised control trial, which didn't recruit, would have been the best way. But actually, as I said, sometimes you just need to think outside the box a little bit. So this is how many centres we now have on board. And this is the sort of split, really, between where those centres are and which of the two methods that they use. So it's a pretty kind of equal split, really, across the country as to which one. So we only launched on the 1st of May, and we've had 10 registrations already, which is phenomenal, thinking we spent a lot of time and effort and money trying to do the randomised control trial. But we're hoping that this is going to give us some really interesting information, and at least tell us which of those two methods is more palatable for parents, which one, if we can show that both of them are pretty much the same and there's not a huge increase in chickenpox in one or the other, which I suspect is what we will show, then hopefully we can actually ask families which they would prefer, because actually those two methods are so different, and yet the centres are quite entrenched in their belief that their method is the best, and not really willing to consider others. So this is just another sort of piece of research, really, that I think makes a huge difference to parents and families in terms of exposure to chickenpox and how to avoid it. So again, if you'd like to get involved or you have some thoughts on this, please email phe.peptalk3@nhs.net as well. Thanks so much for listening.